Good afternoon, everyone, and thank you so much for joining today's ECHO session on COVID. Since we have a bigger group, typically we just go right into the didactic presentation, and today we'll be having Dr. Moffitt present. I will have the slides ready for you. Just let me know when you're ready to advance. And if you'd like, please introduce yourself while I pull those up.
Okay. Well, good afternoon. I'm Kathy Moffitt. I'm pediatric infectious diseases, and thanks for inviting me. They asked me to talk about COVID vaccines in children, and I have to say, if you go ahead to the next slide, and then next slide. I don't have any disclosures. Really exciting time. This week I was like, oh my gosh, holy cow, the vaccines are probably going to be approved this week. So go ahead to the next slide. So you probably heard that Canada approved the Pfizer vaccine for 12 to 15-year-olds, and we're waiting any minute, any hour, any day for the FDA to give emergency authorization use for the same age, 12 to 15. So go ahead to the next slide. So I looked again today because I thought I'd missed it. I found very little online about the Moderna, but I've been able to find a little bit more about the Pfizer. But I have a suspicion that the clinical trials for the Moderna vaccine are not going to be all that different than what we've already been told about the, the mRNA Pfizer BioNTech vaccine. It has been studied in a little over 2,000 adolescents between the ages of 12 to 15. And as you know, the Pfizer vaccine is already approved 16 and up. The Moderna is 18 and up. So this was this age group. And I would expect that then the Moderna is going to be 12 to 17-year-olds in their study. So they found no cases of COVID-19 infection in the vaccine group. And they also looked at the antibody titer, if you want to call it, were substantially higher, the virus blocking antibodies, than they did in the older young people, the 16 to 25-year-olds. Now, what is the relevance of that? We're not really sure, but we do know that other vaccines, we see similar things. So I'll give you an example with the HPV vaccine. The titer that you get, which is the surrogate marker for the usefulness or the protection that we have, because we are not going to be able to prove that everybody is infection-free, and yet we use the titer as the surrogate marker that the vaccine works. And that's been established in many other vaccines. So in the HPV vaccine, we see the 9 to 14, 15-year-olds get an incredibly high titer, even compared to the, say, 15 to 25 or 30-year-olds, and then even the older age, because the HPV vaccine is now approved for women up to age 45. So what does that mean? Well, I interpret it, maybe this is right or wrong, that if you start out with a really high level and you're going to decline over time, it's going to take you longer to decline. And so is higher better? Well, probably it is. We don't know. I have to say I'm not really sure. But it is very reassuring to say that these kids get a good, robust response. So next slide. And then, as I just said a little bit earlier, next slide, that Canada just yesterday, Health Canada approved the Pfizer vaccine for 12 and up for use. And in this age group, they use the same dose that we use for adults. So next slide. Now, you probably have also heard, and these are screenshots off the internet, and so it looks like I'm going to play a video, but I'm not going to play a video. These are what come up. But just recently, in the past 2 weeks, the end of April, the here's an ABC report about starting the COVID vaccine trials for children as young as 6 months. So I'm going to go through how these trials are designed, because they are a little different, because we do not know the dose that's needed for younger children. Is it the same dose that adults, that above 12-year-olds get? And for some vaccines, you need more antigen in the vaccine. So a good example of that is the varicella vaccine. No, not the varicella. Varicella is the opposite. A good example of that is the diphtheria pertussis, DPT, acellular pertussis tetanus. You notice that the DPT is big D, A, big P, big T. And then when we get it later on, we get a big T, little d, A, little p, Tdap. The reason those letters are big and little is the amount of antigen that's needed. And so for children, you need more in the DPT of the diphtheria and the pertussis in order to get an immune response, as opposed to when you're older, you don't need that. So if you inadvertently gave a 6-month-old or a booster to a 4-year-old or 5-year-old a Tdap, that vaccine doesn't count, because we don't know that they got enough antigen to respond. As opposed to, but if you gave a DPT to me, as opposed to the Tdap, it counts, and it's more than I really need, and I might have a pretty sore arm, but I'm going to respond to that. So if that makes sense. But we don't want to have too much response in terms of fever and too much inflammatory response if you really don't need as much antigen in the vaccine. Now, the opposite example of that is varicella and the old shingles vaccine. So there's this much antigen in the varicella vaccine, and the live attenuated shingles vaccine has 4 times as much live attenuated varicella vaccine, because old people need more in order to respond. Now there's a newer version of a shingles vaccine, which we all accept probably we're going to use. So next slide. So let's talk about the 2 that are ongoing in the US and Canada, the 2 trials for the younger children, and then I'm going to mention the other 2 vaccines just briefly in the world. So the Moderna COVID vaccine is called KidCove, and it's a phase 2 and phase 3 study. So the part 1 is the open label, and it's called dose escalation and then de-escalation. So what they're doing is they're starting with the older age de-escalation, means they're starting with the older age, like 6 to 11, and they look at 3 different doses and they figure out which dose is needed. And then once they figure that out, they'll go to the lower age and then down to 6 months. So they de-escalate down the age, but hopefully have an idea of what dose you need. And then once they figure out what the dose is, the part 2 is what we're more familiar with, is the randomized placebo-controlled observer blind study. And they're expecting to enroll almost 7,000 children in the US and Canada. And that's when they figure out which dose children are going to need. So go to the next one. So I just got sent this cartoon. I thought it was actually very timely. Got to have a little humor in our talks. Dr. Gupta would like that. So next slide. So to look a little more in detail, the Moderna, actually I said 6, it's 2. So 2 to 12-year-olds are going to do 2 doses. 50 micrograms or 100 micrograms, and then the 6-month to 2-year-olds, they're going to look at 3 doses, 25, 50, or 100, and really try to figure out what is the best dose that children need to get a response. And again, what they will use is the surrogate marker of the antibody level. How much antibody, how high a titer do you get, and then what is the immune response? Does 100 give way more fever and fussiness and irritability than a 25, or are they going to be equivalent? And will it not really matter? So go ahead to the next slide. And then from the part 1, the dose will be conferred or used in the part 2, and then evaluating a much bigger group to look at the safety, the tolerability, more of the reactogenicity, and then of course the effectiveness, because then these kids are going to be followed and then be swabbed for SARS-CoV-2 virus to see who gets infection or not, comparing the placebo group to the vaccine group. Next slide. So the Pfizer-BioNTech clinical trial, you can go online and find their study site, and they kind of had the data out there a little bit differently, but they're basically doing the same thing. They're looking at different doses of the vaccine and looking at safety and efficacy, and then they're doing a trial. They're planning to enroll a little less than 5,000 kids from 6 months to 11, and they specifically say no previous diagnosis of COVID-19. I think the Moderna is not quite that strict, but don't hold me to it. And then they've said, and I would believe that probably Moderna will do the same, is that if you are in the placebo arm, then at the end of the trial, you have the opportunity to get the real deal. Next slide. So here's where, this is what I've really been able to find. The Oxford AstraZeneca and the JNJ vaccines are doing studies in Europe, but both have been paused because of the controversy over the safety of these two vaccines. So the AstraZeneca, I really couldn't find a huge amount of information, but theirs was only age 6 to 17. And then the J&J has been paused because of the ongoing investigations, even though we've released and we're giving the J&J vaccine again in the US, but they're both on pause. So neither of these are really relevant in the US market right now, because neither of these vaccines are available for use in adults either. So stay tuned. We probably will get some data on children, but I think it's going to come much later than for the two mRNA vaccines. Next slide. So I found this article, and I think it's through nature.com, and it actually is really interesting, raises some points. So I'm using their 5 questions, and I've added to it the 5 questions that we maybe should think about with vaccinating children. So next slide. So the first one is, do we even need to vaccinate children? And, you know, among our medical people, we've had of if children are not the ones passing COVID around, then and they're not the ones who are really dying in great numbers, and they're not clogging our ICU and our hospital, then do we need to vaccinate them at all? So I'm going to bring up some information, and then we can have I'd love to have a discussion at the end. I have my opinion. I know others have opinions, and I am open to what people have to say, because I want to see science, but I also think we have to be practical about it. So next. So they're generally, COVID infections have not been a big burden in children. They rarely develop severe forms of COVID-19. We've had hospitalizations. We had one really critically ill teen whose probably morbidity was being morbidly obese. And they ended up being transferred from our ICU on the ventilator to the HVI, and they went on ECMO. This person went on ECMO and came off ECMO and was recovering. And when they were recovering, they came back to our PICU, and then eventually the kid went home. And I don't know that we've had any more follow-up on them, but they survived. That's the most critically ill. We've had one or two others who've been sick, and the rest really not. Now, we have had some MISC, and I'll talk about what this is. The estimates are 1 case in 1,000 cases of COVID, but I tell you, we haven't seen the number of MISC, we haven't diagnosed the number of MISC cases like some other parts of the country. So it's still a dilemma, and I think we're learning about this. So next slide. So here are 2 pictures that I got. The one on the left clearly is a younger child, but this multi-system inflammatory syndrome in children known as MISC. Big overlap with Kawasaki disease, but the difference with MISC is we must prove that that there has been COVID-19 infection. Usually they're over their pretty mild infection, and then there's this inflammatory syndrome, and they get 3 or more days of fever with at least 2 or more body parts that are involved. Skin with rash, eyes, mucous membrane, lips cracked, then GI manifestations, cardiac, and so at least 2 of these plus abnormalities in blood work, which can be anemia, thrombocytopenia, low sodium, and with elevated either SED-rate or CRP, the acute phase reactants. And the average age of MISC is probably, well, the range is usually 8 to 17 with being in the 12 to 13-year-old. Both of these kids are younger. The one on the right is a 9-year-old. So he fits more in the MISC age group, but MISC has been diagnosed down into younger age as well. So, and the real concern is the cardiac involvement from MISC. So if you talk to any parent who's been through MISC, they probably would say, yes, every child needs to get a COVID-19 vaccine to prevent this from happening. But I will bring this up again toward the end. Go ahead, next slide. So I looked, this comes from the AAP website, and this is the Children's Hospital Association. There's a lot of information. I picked out a couple slides that I thought were interesting. So this is the latest as of yesterday, and it goes through the end of April. And you can see the cumulative cases as of 4/29/21. And I put an arrow where West Virginia is. And the overall percent of children of all COVID cases has been almost 14%. And you can see that 6 states are well over 18, and we are in West Virginia, we're over that 13.8% as well. What does that mean? I don't know. Let's go to the next slide. In the last few weeks, so this slide is all COVID cases, and then the dark blue is the number that are children up to age 17, so 0 to 17. And in the last weeks of this graph, you can see since the end of March, the percentage of pediatric cases is increasing. And the last week, it was 22% of all reported COVID cases were in children. So this has people alarmed to say, okay, we maybe didn't see a burden in children previously, but what's happening and changing now? I mean, one of the reasons is that a lot of elderly and a lot of high risk over 65, over 80-year-olds have been vaccinated. So we're seeing proportionally much less severe COVID and COVID in general in the older age. Many of us adults who were maybe not that old, but have been vaccinated. So are we just skewing it that these are the susceptible ones around? We definitely also know that the 16 to 25 and even to 40, 50-year-olds are a big burden of COVID right now. And those adults in the non-pediatric age are now the ones being admitted, and they're not necessarily all elderly. So the data may just reflect that proportionally it's because we're seeing less in the older age. So next slide. But you can argue that if we vaccinate kids, are we going to achieve herd immunity faster? And again, we circle back around to how much do children contribute to transmission. And I did read in the Dominion Post that 75% of California variants, or what was the 75? Anyway, we have a lot of the California variant in West Virginia, more than in other places, and we have a lot of the UK variant in West Virginia as well. And the UK variant has been attributed to maybe more transmissible. And the jury's still out on whether it causes more severe disease or not. So if the variants are going to lead to more transmission and children are getting proportionally more infection, then maybe we need to vaccinate children. So next slide. Next slide, or yeah, go ahead one. So here's the table of child mortality data, and go one more click. So I circled the last week in April, and they have a table for every week of COVID since we've been collecting data. So I didn't want to put all the tables. I put the most recent table, but you can see that the percent of child cases that resulted in death are 0.01%. And then the percent of children who have died are 0.06%. So not a lot, but it is 303 children. So when you look at influenza in a given year, 100 to 150 children annually die of influenza who are children. This is double or more the number of kids, and we do vaccinate children against influenza. Now, we know that children are probably the ones really transmitting influenza in the community. We definitely know that about the influenza virus. Next slide. So I'm curious as to, I always have to think about this. So I looked this up because I can never remember. So the US total population is somewhere around 325 million, 330 million, and there are 75 million children in the US, making up a quarter of the US population. And then I found this nice little bar graph that I thought was pretty cool, that it's basically from 0 to 5, it's about a third of kids. From 6 to 11, it's a third of kids, and 12 to 17, it's a third of kids. Now, we definitely know that the group to the far right, the 12 to 17-year-olds, act like the rest of us with COVID and get COVID, transmit it, pass it around, are sick. So at least if you're gonna say we vaccinate anyone, we should vaccinate the 12 to 17-year-olds. And that's gonna knock out at least a third, or 25 million, and that leaves, perhaps if we don't vaccinate the younger age, 50 million unvaccinated. So out of 325 million eligible or people, that would leave at least 275 million eligible to be vaccinated. And if the Pfizer gets approved, then anyone 12 and up can be vaccinated. And then we debate whether we're going to vaccinate lower. So next slide. So will the trials in kids work? Next slide. And so that little game of the 25 micrograms, 50 micrograms, 100 micrograms has been described as the Goldilocks effect. So, which bed is too soft, too hard, just right, looking for the sweet spot to find the dose that works and doesn't have too strong an immune response with lots of side effects, because we don't want every single kid having high fever. We'd like the fever to be equivalent to what maybe adults had. One day, low grade, your arm is achy, and that's it. Next slide. How do we know if the vaccines will work in children? Next slide. So again, we've talked about the immune response, and can we rely on the blood test being the surrogate marker? That's the inference that the vaccine is going to work. We really are going to have too few probably symptomatic infections to really measure efficacy in the same way. And we can see that the Moderna was what, almost 7,000, a little less than 7,000 kids, and the Pfizer was a little less than 5,000 kids. So again, questions that we have about that. Next slide. Will children and adults respond differently? So next slide. So I think there is the concern, about maybe an inflammatory response, but we definitely know the 12 to 15-year-olds get a higher antibody response. Is it really clinically relevant? I already mentioned that. Will they get, what levels will younger kids get? But I think the other one that has people worried is, how are they going to interfere with routine childhood vaccines? And there's a window around the COVID vaccines 2 weeks before, 2 weeks after, that you should not receive any other vaccine. So we already are aware during the pandemic that children have been getting less of their childhood vaccines. So this may put a monkey wrench in the kids a little behind, and then they come. So are you going to give them their slated routine ones, or are you going to give them the COVID vaccine first and then hope that they come back in 2 weeks to get their whichever other vaccines? So that's a real worry. When we do clinical trials with a new version of maybe a new combo vaccine or a brand new vaccine, you do what we call non-inferiority testing. So if you're giving a brand new, let's say we have a vaccine against strep throat, and you're going to give it at the kindergarten visit with the other vaccines. Well, you have to be able to prove that all the other vaccines that you're getting at that same time get the same response or better response than you would get normally. So we call that non-inferiority. So here's another cartoon, and I have to say, this is funny, but maybe parents have the decision to whether they vaccinate their kids. And when you're 7 and older, children have to sign an assent to agree to be in a clinical trial. But what if there's a disagreement going the other way, that the kid wants to be vaccinated and the parent says no? So I think this is really very interesting, because kids are aware of how COVID has impacted their life. And a lot of kids are very paranoid about getting COVID, not wanting to get it and themselves be sick or die. I've heard parents voice that, even though the risk is very low, but also not giving COVID to someone else in their family and being very worried and responsible. So we do have to say, how are kids going to weigh in on this? Do kids have a real opinion to say, absolutely, I want to be vaccinated? But then, you have to have the adult and give the guardian parent approval as well. Next slide. So here's the question about the safety. And I think the one real question, go to the next slide, that's been raised is, will it cause an enhanced disease and lead to MIS-C? So what we have seen with this MIS-C is that children, the family has COVID, they had it, say, the beginning of April, the parents were sick, the kids were maybe mildly sick, or not really sick at all, but they got tested because there was somebody in the family. And then everyone's better, and then they come in like now, a month later, their SARS-CoV-2 PCR is negative, but then we test their antibodies. Yep, sure enough, they've got antibodies to COVID, and then we diagnose them with MIS-C. So there is worry that would we cause enhanced disease and lead to MIS-C? I don't know we have any evidence that it will, but this is a question that's been raised. And then, of course, for anybody, this happens with adults, we have not seen other immunodeficiencies or immune immune diseases we haven't seen the vaccines enhance, meaning making their lupus or their JRA or their Crohn's disease worse because they got vaccinated. But I think these are questions that people have raised about children. Because remember, children are not just little mini adults. Next slide. So I would love to open this up to hear what people think. I tend to be on the side to say, I think that we have interrupted the natural spread of this virus because we went on lockdown and because we closed schools. And if schools are wearing masks and social distancing, and a lot of them are still remote, I think we still do not know how much role children really play in and maybe it's asymptomatic, maybe it's not as much, but I think until we really get immunity in this country, in this world, we are going to have, we're still going to be in the pandemic. So that's my opinion. So I'd like to open it up and see what people think, and if there's questions.
Thank you so much for that wonderful presentation. I think we're going to hear a lot about. Even today, I think I saw a study say that less than a third of parents would let their child get the COVID vaccine right away until further studies are done. And I think that's an interesting thought about what the kids think. What if you have parents that think differently, and herd immunity? I think it's just a very interesting discussion that we'll continue having. So I didn't know if Dr. Costella or Dr. Gupta had anything to add before we open the floor up for further discussion.
I don't see any questions in my chat, but maybe there's questions to you in your chat.
Yeah, I think Dr. Moffitt did a great job. I don't necessarily have anything to add, but certainly will welcome taken questions. There's one question that just came in. Dr. Moffitt, I'll let you take a stab at it. I certainly know my opinion and my what my understanding of the situation is.
All right, let me read it. By vaccinating children in the US, are we still taking away resources that could be used for worldwide vaccination efforts? Ooh, yeah, that's a good question. So if we choose to vaccinate 25 million, so the 12 to 17-year-olds, or if we vaccinate all, that's 75 million, and 2 doses, that's 150 million doses of the vaccine. I think we're not going to have the approval for the younger kids until the very earliest September. So I think we're only looking right now at 50 million doses for the 12 to 17-year age group if they haven't already gotten a dose, the Pfizer, if they're 16 or 17. I think that's sort of I think we have to think about that, but I think it is a small number compared to if we're making hundreds of millions of doses. 50 million is a portion of that, but I think that's a very good thought. I think when you look at some countries in the world, when you look at more than half of some developing world countries have half of their population are children. So I think we have to really think that we need to get vaccine for their whole population, or as much as we can, but also being careful in that, in making sure that I wouldn't want to have this happen where we're like, well, we won't vaccinate our children and we'll let you vaccinate your children. No, that can't happen either, because I think there could be, we're not going to experiment on other children in the world. We're not going to experiment on any children in the world. We're going to make sure there's safety and efficacy, and then we need to have the vaccine be available to everyone. So that is one thought that pops in my mind that wouldn't be good. But I agree. We need to get adults vaccinated in the world. We need to get everyone vaccinated as much as we can.
Yeah, I would just add, I mean, I think that Dr. Moffitt did a good job, but I mean, if you're one of the families of the 279 children who have died from COVID in the United States, I mean, at what point, I mean, COVID is one of the leading causes of death in children in this past year. So if you're okay with children dying, then don't vaccinate them. But if we want to really say that we are for, and as a pediatrician, I want to protect every child's life. So I think to say adult person's life is more important than a child's life, I don't think that as a professional, we should be doing that. So I agree with Dr. Moffitt that we need to be addressing the whole issue, but to say we're not going to vaccinate children because that's taking away efforts from worldwide, as a pediatrician, I just have a really, a fundamental ethical issue with that. And
Right.
so I think that, for me, it's a matter of, children do get sick and die from COVID, and they do it more than in some other diseases that we've seen in the past year. And so I just feel that children are as important to be protected from this, and we don't know the transmission. And with more variants coming, we see that children do spread the variants more. So we don't know
Right.
the widespread. There were some studies early on that did say children spread it or had higher viral loads more than others. So that's just my somewhat opinion on that. But I think, to purport that vaccinating children is potentially, not as important to vaccinate somebody else in another place, I think that's not the issue. The issue is we need to get widespread access to the vaccine, and we need to be vaccinating children worldwide. So
Right.
that's just my kind of passionate plea on that issue, that I think children, because they don't vote, children because they're always left out of the equation, and they deserve protection as much as any other person that is on the planet.
So there's another question in the chat, which is a good one. Do you believe under an EAU, will ACIP and the CDC allow co-administration of COVID with other vaccines in kids? I think initially, no. I think the ruling that's going to come out this week or Monday or Tuesday, whenever it comes out, I think the answer will be no. I would certainly hope that in a subset, at least, of children, or I have not heard they're doing a separate vaccine trial, but I think you have to have some data to show there's not suppression of your response to other vaccines with this. So that's my opinion.
Yeah, I was just on a call with Peter Marks, who is the lead of the FDA and the vaccine development, and there's not going to be at this moment, permission to co-administer. There has been some that the FDA, from when they first came out till now, in high risk situations. So for instance, like if you got COVID vaccinated, then you fell and you needed a tetanus booster, like the risk of not getting the tetanus booster in that period, it would seem like you should get the tetanus booster.
Right.
But in regards to just typical like routine administration, it's not going to be co-administration. I think that's going to be incredibly challenging when I think we'll see in the fall authorization or maybe even approval at that point, because some of the companies have said they're going to apply for the full approval of the product by fall. It's unclear what ages they'll go for full approval, because I don't know if they'll have enough data in that 2 to 11-year-old range. But I think it's going to be challenging for everyone who's maybe getting their first time COVID shot and then the flu vaccine. And I think that's going to be an interesting challenge that we'll have to deal with in the younger age population, because there's not that co-administration. And as Dr. Moffitt said, even if we'd start now, I'm not sure we'd have enough data to really know the effectiveness of that strategy by this fall. So I think for right now, that's what we've been emphasizing in the AAP, that every child or teen really, unless you're 12-year-olds, should be trying to get updated now on their immunizations, because
Right.
you're not going to be able to have that co-administration. And so really you're looking at like a 5 to 6 week window that you can't give any other vaccines when you've been vaccinated against COVID.
Right. So there's another good question. Are there currently antibody tests that are reliable to the general public, not within a clinical trial? And this person said, I'm having more patients tell me that they or their children are getting antibody tests. So we now have here, and I think other places, we have 2 antibody options. One is against the M protein, which was the first IgG antibody that we've had here. And that's what we use when someone comes in, and that's the routine one we use. Now, the other one is looking at the antibodies and to the spike protein, which is what we get vaccinated against, and looking at And then people are even developing IgA, IgM, and IgG to the spike. A would be from natural disease, M and G could be from the vaccine. So the difference in the ones that commercially are available versus the clinical trial is the clinical trial, they're vetted a little more in terms of they're quantitative. So they give you a titer, whereas the ones here are qualitative. They're either positive or they're negative. So I think that it gives you information that you have an immune response, but it is not something that we should be doing to decide whether you're vaccinating someone or not. The recommendation is whether you've had COVID or not, yes, you should receive either one dose of the J&J or two of the one of the mRNA vaccines. So Lisa, do you want to comment a little more on the antibody testing?
Yeah, I think that, certainly with all testing, we're continuing to learn more. I mean, I think we all need to have better variant testing or better, capability to quickly detect variants that we're still striving to. And I think that's tough with the antibody testing as well. I've heard some places that will only accept the PCR still. There's some places that will accept an antigen test. When I was shopping at Sam's Club, you can now buy antigen tests at home for $20. You can get the buy next now. I took a picture of it. My husband was like, "What's so shocking?" And I was like, "These are COVID tests that you can buy." And they were the buy next now antigen tests. So it was $20, 1996, I think. So, but anyway, I think that, this area is still evolving. I know that the state is looking at additional testing, particularly in school-age children, as we progress to the fall and what that looks like. But I don't really have any. I think Dr. Moffitt explained the science really well. I think the answer is we've come a long way, but we're still learning more.
Yep.
And I think we've seen it, at least I know, and Dr. Moffitt at our institution, like they just, now we're to the point where we're using the COVID test in our BioFire panel, because they, I think, got to the part. So I think, there was that question all along about flu RSV season and your testing, like, is there a way to just test for them all? So I think perhaps this flu season, or an RSV season, perhaps there will be more tests available that can kind of just do that combined testing, whether that's through the BioFire or other means.
And there still is the question, I said at kind of the beginning when I was talking about your titer that you get, how long do these last? I think we don't know. I had an interesting patient who was actually, it was a 12-year-old who came into the PICU in septic shock, and we didn't figure out the cause of his septic shock, but we were going through the MISC protocol. And so I asked, we're talking about COVID with the mom, and the mom said, this was just recently, and the mom said, "Oh, this kid had COVID last March. I'm sure of it, but testing wasn't available." So we did the antibody test on him, and sure enough, it was to the M protein, he had an antibody. I would presume, and we determined he didn't have MISC, his illness was not COVID now. I think that was real, and that really reflected what he had. Mom described the symptoms and what he had lingering for a while. So at least for that kid, his antibody, if he really had COVID in March of 2020, he still has an antibody present. Yeah, but we just really are learning all these things. Are we going to need a booster? I'm going to declare that we probably are. And maybe it will be a variant, tweaked a little with the variants. Maybe we'll find that, 50% of us decline in our antibody levels 9 months or a year after our vaccine. So we need a booster. Maybe it'll be 5%, maybe it'll be 75%. We really don't know. And we base our repeat vaccine doses on the fact of looking at what happens in the population. 10 years for a tetanus if you haven't had a laceration, 5 years if you have a big, a laceration, a wound, and that is based on how much population loses their tetanus antibody over time. And most people maintain an antibody in the 5 years, but between 5 and 10 years, that goes down. So we have data on other vaccines and others where we know pretty much that if you respond and you have a titer, you're protected for life. Measles is a good example, sort of. I mean, we really think the ones who have no titer probably are the non-responders to the vaccine, but we do believe that your antibody is there and you're good for a long, long time until you get old and then your immune system doesn't work. So those are all things that we do not know yet, but we are going to learn in the probably even to the end of this year, we'll learn some of that. Into 2022, we will learn, what are we going to need in terms of subsequent dose.
Thank you so much. Absolutely. Those are great questions and fantastic answers. And sometimes I think the uncertainty does make people nervous of not knowing 100% something, but
right.
We're getting there. And that's exciting news. Does anybody else have any questions? They can chat them in if they're comfortable doing that, or even use the raise hand feature, or just unmute is fine. All right. Yes, Jennifer said, thank you for the excellent, thoughtful update. Absolutely. Carl said, any ideas? West Virginia schools will require COVID vaccination.
Oh, I would love it. I think our public health is on board with that. I don't know that the rest of the state will. I think they have to be approved and not be under emergency use, first of all, to consider that. And otherwise I just say, we'll have some big fight next year in January, February in Charleston with some bill that will try to prohibit that. So I don't know. I actually am really was thrilled to see that at least in Mon County, the health department went to the schools, to the high schools, and offered vaccine. Now they weren't mandatory, obviously, but we have to vaccinate where people are. I think that's a good example. So I'm thrilled with that, and I'd love to see them go back now to get the 12 and ups.
So they are, just to interrupt. So we've already assessed, so we already have numbers, and from a state perspective, we've been ensuring that we have enough Pfizer vaccine on hand that based upon, many of us thought that the authorization was going to come this week. There had been some discussions that even yesterday we're going to do it, but it's pretty clear ACIP is meeting on May 12th for an emergency meeting. So I think that, we're looking at May 11th or May 12th, probably May 11th, FDA makes their, and then May 12th, you'll see ACIP meet is what I think we'll see. I don't know for sure. In regards to the mandatory, Dr. Moffitt has also done a lot of advocacy on this. I mean, the vaccines that are under compulsory mandatory immunization thus far have been around for a really long time. Every year we have to really work hard from a public health standpoint to maintain that strong public health policy. We're one of 5 states that have the recommended policy. So I think when you talk about making a vaccine like this mandatory, what potential risk are we placing on those other vaccine laws? Because based upon what the current makeup of the legislature is, you are potentially placing at risk eliminating further. So I think, I'll be honest, I'm a little, I think that we should be educating individuals, getting individuals to choose to be vaccinated. I think until we have an approved vaccine, I think this vaccine we need to learn more about it. And we're still learning more about it in regards to length and how many boosters you'll need. Maybe we'll learn it's a 3-shot series or it needs to go down. I mean, I don't think we quite know enough yet because the variants are still very much present. And so I think it will be a while, particularly in our state, before you would see it mandatory. And I think that's why it's the onus on us as providers to make sure that we are providing enough education so people can make informed decisions and ultimately choose to be vaccinated. We know from our data in West Virginians, people want this to be a choice. And whenever people are told they have to do something, that is something that it actually puts them further down the vaccine pendulum of not choosing to be vaccinated. So I think it's there's certainly the public health perspective of that. I think you've seen some colleges mandate it. WVU is requiring individuals to identify and confirm if you've been vaccinated or verify your vaccination status, but it's not yet been made mandatory. And so it's going to be certainly an ongoing discussion and likely debate. And, it'll be interesting to see if some states do make it mandatory. I agree with Dr. Moffat. I think until there's a full approved vaccine, it's going to be hard to do some of that type of, we already do that right for flu, but I think that the jury is still out in regards to what will be required for COVID-19 vaccines.
Okay.
Again, great questions. All right, if there's nothing else, my only announcement is we'll be sending out an email for the next COVID session to keep you up in date, so be on the lookout for that. And before you leave, could you please participate in the poll? It'll just take a moment for us to kind of decide what we're going to do for going forward with the COVID session. So just give me 1 second, please.
Thank you, everybody.
Thank you so much.
Thank you, Dr. Moffat.
Thanks.
My big question was whether the school will do the WVU approach, which is kind of interesting. Like when we get such a percentage, then you can do this or that as a population. Maybe you can have, the schools might say, not mandatory, but if your high school has 60% or 80% or whatever the number is, then you can have people in the stands for the football game. Where it's a community decision, because it really is a community benefit. And that might be a way to do this, because WVU's done that. Like when they get to there's all these, if you watch the thing they did this morning or listen to it, there's all these thresholds. When we get to this number, then the rec center opens. When we get to this number, then I don't know. I don't think they mentioned athletics, but you could use things like that are percentage-based incentives for the population, not the individual.
That's interesting what the NCAA has done. I went to talk to one of the teams who was, when the kids on the team, the young adults on the team were wondering about getting vaccine. I knew the coach, so he invited me and I went to talk to them. And he said that the NCAA is saying that you won't, if you're vaccinated, you won't need the weekly COVID tests, and you can go to NCAA events. And they're not yet saying you can't come if you're not vaccinated, but he said it could really limit, you'll have to quarantine if you're not vaccinated and you're exposed. And so you as an athlete, so it's trying to say you don't have to, but here's the incentive of why if you get vaccinated. Now I should follow up with him and find out if he knows how many of the teammates decided to be vaccinated or not. I've also been told, this is at WVU Medicine, the hospital. So we can ask someone, an employee, if they've been vaccinated or not. But the lawyers say we are not allowed to ask, if they're not vaccinated, we are not allowed to ask them why they're not vaccinated. I thought that was interesting. You can get around that a little bit I've thought about this. I haven't really encountered anyone, but you could say to them, so if they say, no, I'm not vaccinated, you could say, well, could I help you with any of the concerns you have about reluctance to being vaccinated? And then you could start a conversation that way without saying, well, why are you so, okay, I won't say that. Why are you not vaccinated? Anyway, it's interesting. But I think, Carl, that's a very interesting way it's a collective responsibility. And here's what we gain by being, that's what we have to do. We have to make it individual, but we also have to let people know that collectively we benefit from people being vaccinated.
Yeah, I was thinking about I was listening, and my wife was on the thing this morning. I'm like, what they need to do is say, when we get to some percentage and make it high, like 80, that then we're going to reopen the student sections for the athletic events at normal capacity. They'd be there like that. Because if the kids want to go to the football games, the basketball games, they would, I think that would be an amazing population incentive.
Right.
You know, everybody do your part so we can open the student section at the football game. I think they would be there.
I hope it would be.
Anyway.
I don't know if you've been to some of the football games, but they were probably at not max capacity when they could have been pre-pandemic. So hopefully our football team will get a little bit better. I just think the motivations that we have to understand of why people are choosing to be vaccinated are not the same for everyone, and what the potential risk that may have if we do it prematurely, and what are the liabilities related to that. I think the governor tomorrow has talked about a percentage that he will indicate to remove the mask mandate. Me personally, I'm wearing a mask for the rest of the winter any other time I work in the hospital. This is like the first time I've not had the kitty crud for the first time since I've been like a resident. So I will gladly wear my mask throughout the fall from now on. But I think it'll be interesting, and we have to be careful what we wish for when we don't know about these variants, and then when we backtrack, and particularly with additional vaccines. So I think it's an interesting concept, but I think it could boomerang and have a effect moving forward if we do see a new variant strain emerge that isn't vaccine, not covered by the vaccine until we get one developed, and then we're placing people at increased risk.
Yeah, my logic is just the more people we can get vaccinated faster, the fewer people there are to be little single-stranded DNA factories and make their own variants. That's my logic. Is that if you don't get the disease, you don't make a variant, and that's individual by individual by individual.
I think it just goes back to the point before. Until we get a worldwide supply that's sufficient for that, what we're seeing in India, the double variant in India right now is super scary. So until we can get to that where we can do that across the globe, I think it's going to be unfortunate given our global society that, we need to really have production that we can do that worldwide. And we're closer to that point, but we're just not there yet, because a lot of these variants that we're seeing weren't generated in the United States. And I think the one in India is particularly concerning.
Absolutely. Okay. Well, thank you very much. I'm trying to figure out how to make this, not make it mandatory, but make it really desirable. It's been interesting having my discussions with my patients who are coal miners and pilots and things like that, and talking to them about vaccination and skipping the crazy people. The truly crazy people. It's really an incentive question for most of the people. Some of it's information, mostly it's incentive. I've only had one really, really crazy person that had to do with zombies and 5G, and I just stopped and said, well, when you decide you're ready, we'll hook you up. But the rest of them, it's more like, well, until somebody makes me, and that's really what they say. And it's just like, okay, let's push a little bit at a population level, not an individual level. So anyway,
no, completely agree. I think it's the same thing with flu. Like people are like, oh, the flu is fine. I wouldn't get a flu shot if it wasn't mandatory to get it, because people don't think the flu kills anyone. I think we're going to have that ongoing battle with this as well. So